Digital technology allows for remote consent and onboarding, which, and assuming that you have your IRB approve all the things, you can recruit anyone from anywhere. There's a huge concern about bias sample recruitment. If you're just, in your one little university town, recruiting the people that you find and are able to get, you may not be getting a representative sample for whatever you're studying. But digital recruitment opens that up entirely, and you can, recruit from as broad a sample as you're approved to. So I think that's really a great way to have that technology integrated. Something that I think is also really dear to my heart is data breadth and depth. So what I mean by that is with digital technologies, things like the ECAP provided, by Joanne's team, you can collect a lot of data passively and really granular data. So, with that medication device, you can know when someone is taking their pill, not just did they take their pill. And that's really important. Daily, sometimes multiple times per day, if you have a medication that has multiple doses, you can get really granular data on that dosing. When you can't always get from self-report, because people will lie and say they're taking their medication. That's what they're saying to their doctors, right? But in terms of actual adherence and actual medical outcomes, we know that most people are not adherent to medications. Most people are not adherent to physical activity and proper diet. So having technology help with that intervention really can drill down into that. And another thing, talking about the ECAP, but also Fitbits, is passive data collection, ease of data collection. So the benefit of the ECAP or a Fitbit device is it consistently measures data regardless of input from the participant. So you're reducing burden on them, but still collecting a lot of that broad granular data I was talking about. So, I think for the ECAP, a person just needs to fill their prescription to the bottle, which a coordinator can walk with them over on the phone. You don't have to be in person. You don't have to have direct. You can even make a video to show them how to do it. And I know that there are some onboarding materials that involve that kind of thing. So sometimes you don't even have to do it yourself. It's part of what the company provides when you get that service. And after that, the data is collected with no burden to the participant, as opposed to, even if you think about, for a simple questionnaire, the burden of finding a pen, picking it up, recording it on a set piece of paper, keeping track of that piece of paper, and then giving it to the research team. It seems stupid, but it's a lot of steps. And if you have passive data collection, there's no burden to the participant, but you still get that high quality data. So I think that is a huge, huge aspect. Text message interventions, another type of technology where if you send out intervention to someone, they can respond via text. You track what they respond, and you know the time it arrived. So you know even more information than you would previously. All of that kind of breadth and depth of data allows for adaptive trial designs, which is kind of becoming the bread and butter of what I'm working with and with the team at Institute of Health System Science, personalized trials and adaptive designs, where the intervention is not just a set paradigm, it's based on the data you're receiving from the participant. So the data you're collecting is not only used to evaluate your intervention, it's used to alter your intervention. A big focus of our center is on personalized trials, where the unit of analysis is not the population, it's the individual. So the way that works is you have a crossover design where you give someone one or more interventions and a control, and they receive them kind of in blocks of time. But you're doing continuous data collection over the whole point for them. And what your goal is to identify is which treatment works best for that individual, not necessarily what the treatment effect is for the overall sample or the overall population. It's really cool, but the problem, it's been existing around for forever. N of 1 trials have existed as long as research has existed, but the burden of them has been very significant, because if you think about it, you're delivering an intervention consistently, you're measuring your outcomes consistently, and you have to analyze all of that information at the individual level. So what we have done, and what I've been really proud to be a part of, is a bit of an automation of that process. So when we collect data for our personalized trials, it comes from multiple data sources, is downloaded, and then automatically cleaned, analyzed, and then presented to the individual in a participant report via a PDF that shows them what interventions they engaged in, what their adherence was to all of those interventions, and then what the effects of those interventions were on the outcomes of interest. So it's a lot of information, but the goal is to provide individuals with a lot of information to help select the treatment that works best for them. On medication adherence, providing someone with a feedback text message saying, you didn't take your medication as prescribed yesterday, right? Which is, a little big brothery, but that's the whole point, to have people with that personal feedback, to let them know that, we're paying attention, we're tracking, and we're trying to help. And I think that that's a really a strong benefit of technology for research. Measurement of adherence using digital technology not only affects how you evaluate the effectiveness of your intervention, it also helps guide you in future treatment selection, because adherence is an important moderator of the effectiveness of your intervention, but it's also an outcome. Mm-hmm. So, I think adherence is a huge issue for medications, because if there's side effects, if there's a burden, even if the pill is too big to swallow, all of that is an important factor to judge whether this treatment is feasible for this individual or not. Mm-hmm. So I think adherence is huge. It helps in a couple of different ways. From the kind of coldest and most cynical, you develop the effect sizes and pilot data for future grants, right? So just understanding where you can go with what your intervention strength is. But beyond that, you have the potential to measure mechanisms of your intervention, right? So if you collect a lot of data and you can collect it via technological means, you can measure mechanisms of how does it build self-efficacy for taking medication? Is that the way that it increases medication adherence? Or, you can look at moderators. There are just certain things like perhaps this individual doesn't take pills on a Tuesday. And if you have enough time points and enough data, you can really tease it apart with granularity. And also going back to what we were talking about briefly, those measures of adherence and feasibility that you get with granular data are so essential, right? Because Joanne's point of, if adherence drops over time, and you have that, you can really look at those kind of trends over time. You can identify when adherence starts to lag and figure out maybe you need a booster for your intervention. Maybe you need a different type of intervention to intervene at that point. And when you have that kind of granular data you're collecting, you can really adjust that. And sometimes if you're lucky and you're looking at your data, not doing primary analysis, we don't want to talk about that, but if you're looking at your data over time and you have an adaptive design, you can work with that as it's being collected. So just all that wealth of data, you can do so much with it. And it's also a great opportunity for collaboration. If you have someone who has skill sets that you don't have, but you have the data, you can work with them. You can expand your academic partnerships. Students can work on your data. There's so much you can do. If you collect more data, there's so much you can do that you just can't if you don't collect that breadth of data. Phenotyping is a huge issue in terms of my joking example is a person doesn't take meds on Tuesday, but that's a very real consideration, right? Because it's You can identify phenotypes of individuals who don't respond under particular circumstances or under particular conditions, right? So maybe this individual has a really poor time getting access between prescription bottles, right? So between fills, maybe that's their pain point. And if you have a large period of temporal data where you see, consistent adherence throughout, and then when it's time to refill the medication, there's a huge gap. Digital and technological data collection provides you with multiple measures of feasibility. So when you're writing that pilot and feasibility studies section of your NIH grant, you can not only say, we had Cohen's d of 0.26 for our intervention, right? What you can say in addition to that is that we have X number of data points. We have individuals who are adherent on 86 out of 90 days to the intervention metric, right? You have a lot more granular data that you can report. And feasibility and scalability, what you have is really nice measures of the cost-benefit ratio for individuals, which is, of course, NIH is always interested in. I'm not a medical economist, but and the cost effectiveness is not my specialty, but I know people who are, and having that more data to pass to them to quantify the effect size, not just in the context of what your trial did, but it's a cost benefit analysis of this is what it can do at a larger scale. And, showing technological interventions that improve reach to get individuals who are minority underserved populations, to show that breadth of recruitment and applicability, and also the fact that your intervention works for those populations. NIH is extremely interested in that. So having those types of details for your feasibility section of your grant is essential.